the case of PH is whenever a PH presents to you, actually this talks for itself. This is a lady who came to us with a severe pulmonary artery hypertension, and I asked her, is she pregnant? She said, no. Look at the face, and it's telling you that there is probably an etiology sitting there. So it's always good. A very good clinical examination is the first step of evaluation of a pulmonary artery hypertension. Next. And remember, it's ASD, which is very commonly taken as a cause of pulmonary artery hypertension. And as in the previous slides, it's very important to look for some other cause of cyanosis which could be misdiagnosed as ASD. And most of them, we have a systemic venous anomalies, or as the last slide, next, as we had the Abernethy in previous Prashant's talk. Next. And most importantly, a contrast injection would help us guide in many of these situations. It will tell us about the systemic venous anomalies. It will tell us about the presence of pulmonary AVMs, which could be secondary to portosystemic communication as a cause of pulmonary artery hypertension. When in doubt, in a ASD with cyanosis and considering pulmonary artery hypertension, it is always a good idea to subject them to a contrast injection. Next. Let me start with a 56-year-old girl lady who had a case of ASD, which was diagnosed during pregnancy, has dyspnea and exertion, had fever. She was managed as LRTI for 3 days at a local hospital, discharged without clinical improvement, worsened, and again admitted for clinical evaluation. Next. So each time she would present with a chest infection in the emergency and was labeled as ASD with severe PH. She was not able to lie down, was tachycardic, saturation was extremely low, 42%. There was mild pallor, JVPs were raised, and there were crepes all across the chest. This is a usual presentation of a scenario. The examination, there was a RV apex, there was a S2 which was wide and a fixed split, a medium pitched crescendo, decrescendo, short ejection murmur, and a short blowing PSM at the left. So there is a murmur of TR and the very soft ejection murmur across the pulmonary vascular bed. There is a liver which is 3 cm below the margin. So presence of ejection systolic murmur should always be a pointer that probably this PH may not be absolutely an Eisenmengerization. So this is a soft clue which can easily be taken in examination. Next. So ABG suggestive of type 2 left respiratory failure. The ECG was tachycardia. The patient was intubated and put on a BiPAP, and inotropes were initiated. Next. So this is a usual scenario they present to us with this particular pictures, bidirectional shunting ASD, IVC which is dilated. I'm sorry for the echoes, but the windows were very, very poor because there were chest issues, and the ASD which was bidirectional shunting with a RV pressure of 85 against the systemic 110. So we have next. So we have a patient whose TLC is high, who has got diffuse crepes, who is a known case of ASD with query Eisenmenger, which has been labeled, and who's presenting with repeated chest infection. Each time she presents in an emergency, she presents in this particular state and is being discharged. Next. So this is the X-ray, which is definitely showing diffuse abyss. Next. So her CT chest shows a right lower lobe bronchiectasis with infective changes. The patient is extubated. She's on BiPAP, but we are not able to remove the BiPAP. She always has been on BiPAP with a saturation of around 90%. Next. But her ASD has become much better. The ASDs have now started to shunt left to right. Her PA pressures have now come significantly down to 50. It is at this time. Next. Next. Can escape this slide and then press the next. So whenever there's a chest issues, you have a crepitations which are there. Look at the IVC. The IVC contractility has become much, much better. So each time she's presenting in an emergency, next, presenting in an emergency, she is having the chest signs and she's labeled as ASD. So there's a ESD with chest infection, but we thought we'll just wait, but the problem is we are not able to come off the BiPAP. Next. And she has been started with pulmonary vasodilators by one of our few of the adult colleagues, and she's been afebrile, but we are still not able to come off, so we decided to go to the cath lab. And cath lab, there was torrential flow into the lungs. So what is actually next? So what is actually happening? This particular bronchiectasis patch which is there in the chest gets repeatedly infected. The flow which is there because of the ASD is further compounding the whole issues. So we decided to balloon occlude it, look for the EDs, and then go in for the occlusion of this ASD. Next. Ever since she has closed this ASD, we have closed this ASD. The patient is doing wonderfully well. If you see, it's 2015 this ASD closure was done, and she hardly had an repeated. The lady who was getting admitted almost every second, third day with chest infection. We go to the next one. This is the follow up again. Next. So ASD is there. So her PA pressures are around 40. And yes, there is a mild pericardial effusion, and symptomatically she is doing wonderfully well in follow-up even now. So what was happening is this increased flow across the ASD was repeatedly confounding her bronchiectasis and probably tackling a volume over an ASD, additional volume of a pre-tricuspid shunt helped her out. Next. Similarly, this is one of the other cases which we published in, this case was definitely published in 2017 and been followed up. Next. So it's very, very important whenever we have a ASD with a systemic anomaly. Whenever that means there's an apico-caval juxtaposition. That means IVC is opposite to say a situs solitus with a dextrocardia or a situs inversus with a levocardia. Always think of an ASD which is streaming in such a way. The intratracheal septum is streaming in a way that ASD is causing desaturation. Next. So this we published as the cases of apico-caval juxtaposition. Next. In series, which were actually congenitally corrected TGAs with ASDs, which was as a cause of central cyanosis. This was ASD with cyanosis, which were actually not PAH. Where most of them were misdiagnosed as PAH and being followed up because of the ASD and cyanosis. Next. So this is another interesting case of Lutembecker syndrome. Remember, left-sided heart is always a neglected heart of the ASD, and we had this young gentleman who was a case of ASD with a very good ejection systolic murmur, but was having a PA pressure of a TR gradient of 110, and this was and a cyanosis. What turned out to be he had a Lutembecker, which was cause of severe severe TR, and cause of TR gradients being high. Once we closed off the unroofed sinus, the patient is absolutely normal with normal pressures. Next. So this is one of the another interesting case with ASD with malaligned septum. The video is supposed to play. Just click on the video, please. So once the you look at this malaligned septum, and this malaligned septum was a cause of the blood getting desaturated into the systemic circulation. This was a 1-year-old child with ASD with cyanosis, and once the ASD was closed, the systemic saturation resolved, and luckily there is nothing impinging on the adjacent structures. Next. The large VSDs are not always inoperable. This was again an adult gentleman who had a significantly increased QPQS in spite of being at a late age with a large VSD. The patient was very reactive, and we could close it with a very large VDA device, and the patient in follow-up is again doing well. Next. Whenever there is a case of PH, we should always look at some underlying cause. Next, the 7-year-old girl who had a large PDA with bidirectional shunt. There was a suspicion of coarctation with dilated male pulmonary arteries and normal LV dimensions. Next. But what was happening was this particular left bronchus was getting compressed with the dilated left pulmonary arteries. So once the patient got intubated, the LP opened up, her lungs opened up, her PA pressures really came down. Next. And recatheterization showed a significant QPQS with PA pressures which were actually systemic because of the large PDA and associated coarctation. Next. She underwent a covered stent implantation due to descending aorta, and following it next, her PA pressures had significantly become better of 60 against a systemic 120 with mean of 43. Definitely there is some amount of PAH, but considering her QP is significant, we expect these PA pressures to actually respond in follow-up. Next. So, not just these cases, there are many cases of PH which are misdiagnosed. Many of them there's a small slide which tells about the cases of PH being misdiagnosed as methemoglobinemia with upper airway obstructions. Very interestingly, we had a very small child getting intubated with 2.5 tube, a 7-year-old child, landed in emergency with ASD with PH, but turned out to be upper airway obstruction. And once the tonsillectomy were done, her PA pressures actually regressed. The spinal dyspnophies, connective tissue disorders, associated shunt lesions with VSDs sitting in remote areas At times there's a ASD with severe PH with VSD which was very anterior and was not actually visualized well. So once you visualize it well, we did a PA banding. Subsequently, the patient underwent PA banding and VSD closures and is okay. And of course, associated obstructive lesions such as mitral stenosis and coarctations, such as Lutembecker, one of the cases which saw, are some of the cases which should be actively investigated whenever we have a case of pulmonary artery hypertension. Thank you.